Very good evening to everyone, and I'm very happy and thankful to the organizers of ESI Satellite Symposium team to have given me this platform, specifically so because it bears the name of Dr. Bhandarkar sir, and it gives me a platform to share with my colleagues, dear colleagues at KM. So adrenal mass, when we say adrenal mass, it's a very common problem. So much common that in the past decade, we have at least 4 to 6 consensus guidelines, white papers by various organizations which guide us to say how to deal with this problem. But how common is the problem? That depends on how we decide to look at it. So prior to 1970s, when CT scans came to use, prior to that, in whole of the published literature, there were less than 200 clinical described cases of non-secretory adrenal tumors. And when CT scan became available and became routinely used in 1970s, thereafter in various radiological studies, which are specifically CT-based studies, the prevalence of masses are close to at the max 4%. Now, this is a huge prevalence, considering that we all work in parts of, in cities where at least a number of city centers are working and doing at least 100 scans a day. We expect 2 to 4 patients of adrenal incidentalomas to come to us. So it has that magnitude of a problem. So how we encounter an adrenal mass? In my mind, it's very simple. Either we seek out the mass or the mass seeks us out. Now, the first scenario, when we seek out the mass, this is how the traditional conventional endocrine teaching goes, that a patient comes with the clinical symptoms and signs of either hypo or hyper functioning of the adrenal gland or any gland. We do a relevant hormonal investigations and we have made a certain clinical diagnosis in our mind, and then we do directed specific radiological investigations, and that takes us to the final diagnosis. Now, what hyper and hypo functioning in terms of adrenal gland, my audience is too elite and too learned today for me to spend any more time on this slide, which enumerates the various hyper functioning and hypo functioning syndromes of different layers of adrenals that we know of. The other scenario, when the mass seeks us out. Now, this is the scenario of a true incidentaloma when the CT scan has been done for other indications other than a suspected adrenal pathology, and there we are faced with this situation of an adrenal mass which looks at us, and it is our responsibility to pluck through all the clues and get to the diagnosis. Now, this scenario can, for convenience sake, can be divided into 2 setups. An oncology setup where CT scans are routinely done either as a part of disease mapping of the primary tumor or done at varying points of times during the therapeutic response monitoring. And the other scenario is non-oncology setup, which is coming up very rapidly now as a part of just routine annual checkup when a USG is done, which reveals a adrenal mass, or in various causes of abdominal pain syndromes. Now, I will quickly take you through the journey of our understanding of adrenal CT right from early 1940s. During those times, the way the people used to look at adrenals was doing a retroperitoneal air insufflation and then taking X-rays at various angles to with an attempt to look at how the adrenals look. This was followed by attempts at cannulating the adrenal veins and doing adrenal phlebography or doing a renal artery arteriography with an attempt to look at the morphology of the lesions, guessing from its vasculature. Then iodocholesterol scintigraphy gave some idea about the functioning of the adrenal cortex. And then in 1970s, when the adrenal CT scans came up, there were detailed studies which delineated the precise morphology of even the normal adrenals. Now, with the advent of CT, the lesion detection became very easy and, more importantly, very frequent. And now the onus of responsibility went from lesion detection to lesion characterization. The radiological characterization of the lesion, by that we mean to be able to differentiate on the basis of radiological characters the benign lesions from the malignant ones. Now, benign lesions are predominantly adenomas, because the other benign lesions like myelolipomas and cysts, they have very characteristic radiological features which make their diagnosis very easy. So it is only adenomas which sometimes pose a diagnostic challenge. As against the malignant group, which is termed as non-adenoma group, which in earlier studies mainly consisted of metastasis because those were the oncology series patients. And later on, the other malignant adrenal masses like adrenocortical carcinomas, pheochromocytomas, and lymphomas to that extent came in this group. Now, what parameters do we have to rely on to make this radiological differentiation between adenomas versus non-adenomas? They are a morphological parameter like the size and the attenuation, the HU values. When we talk about the size, we know that adenomas are smaller lesions, mostly smaller than 4 centimeters. But having said so, non-adenoma masses have a significant overlap in size with adenoma masses, rendering the size a less useful parameter in this differentiation. Then the next parameter we look at is the attenuation value. The baseline attenuation value, we all know the determinant of that is the lipid content, the fat content of the adenoma. More lipid rich the adenoma, darker it will look on the CT scan and lesser the HU it will have. To signify that, a lesion which is having a baseline HU of 0 will give us 100% confidence that it is benign adenoma, but only 40% of those adenomas will have such a characteristic. So coming to a optimum threshold, we know that conventionally baseline HU less than 10 gives us a specificity of 98% for saying that it is a benign adenoma with a sensitivity of 70%, which is acceptable, but which also means that 30% will be lipid poor. They will have baseline HU more than 10, signifying the need for looking at other parameters. Now, the other parameters which we look at are the attenuation values at various time points after we give the contrast parameters. So how do we do an adrenal protocol CT at our institute is, we do an unenhanced phase CT at baseline, we take a scan, then we give the contrast, and after giving the contrast at 20 seconds, we take another scan, which we call as arterial phase. At 60 seconds, we take the third scan, which we call as the early venous phase. And at 15 minutes, we take another scan, the last scan, which we call the delayed venous phase. Now, in characterization of the adrenal masses, the different parameters, the HU values at different phases have been studied to see how they help us in differentiating adenomas versus non-adenomas. So far as unenhanced phase HU is concerned, we had just discussed that unenhanced phase has a great value in detecting adenomas if it is less than 10 HU. The next parameter which was studied was early venous phase, 60-second early venous phase HU values. But when it was seen, similar to the other things which what we noted was there was a significant overlap between the early venous phase HU value between adenomas and non-adenomas, signifying that both adenomas and non-adenomas by 60 seconds take up contrast to a similar extent. So making this HU values at early venous phase less useful for us to make the differentiation. The next which was studied was a delayed venous phase HU values. Now these delayed venous phase HU values had some utility because it was seen that the non-adenoma group had retained the contrast by 15 minutes to a greater extent, giving rise to higher HUs than the adenoma group. And different studies propose different threshold cutoffs to suggest that what level of delayed venous phase HU should be there to call it confidently a adenoma. And various studies have given a cutoff from 24 to 30, giving a sensitivity of and specificity which is quite reasonable for that. Now, the other parameters which we all know of are washout parameters. Now, washout parameters, what it means is when a lesion has taken up the contrast at 15 minutes delayed venous phase, what amount of contrast or what percentage of contrast that it has taken by early venous phase has it given away or has it washed out. That is what we call as the washout percentages, the relative and the absolute percentage washout. Now, a landmark study which came up from the Michigan group in 1996 gave us what we routinely know today, the thresholds for absolute and relative washout percentages. Absolute more than 60% and relative washout more than 40% is what is indicative of an adenoma with pretty good specificity, 96 to 100%. And sensitivity in this study was also good and acceptable from 88 to 96%. Several studies after this study was published confirmed the findings, which made us understand that adenomas are good washout masses. But later studies which came up with significantly larger number of adenomas have challenged the sensitivity of 88 to 96%. And according to those studies, it was seen that around 20 to 30%, this is an average figure, it might range from 5% to 45% of adenomas are actually poor washout adenomas. So with that in mind, how do we summarize the radiological approach to adrenal masses? The adenoma 70% will be lipid rich, stating that baseline HU will be less than 10, and 30% will be lipid poor with baseline HU more than 10. In this group of lipid poor adenomas, we do washout studies and we will get the answer in 80% of the patients, which will be good washout. Around 20% of the patients will have poor washout with absolute and relative percentage washouts less than 60 and 40%. How do we approach this poor washout lipid poor adenomas? It is individual case to case basis. For us, if the patient is having, if an adenoma is well looking, 3 centimeters homogeneous mass without necrosis, without anything, patient is asymptomatic, we might even decide to observe these patients for at least 6 to 8 months to demonstrate an interval growth of the lesion. In radiological literature of adrenal masses, stability of the size of the lesion over a period of 6 months to a year is considered to be diagnostic of a benignity of the lesion. That approach can also be undertaken rather than a aggressive approach of either biopsy or surgery. When it comes to non-adenomas, they are lipid poor lesions with baseline HU of more than 10 and they would have poor washout. And this behavior is very well followed by metastasis, ACCs and lymphomas. But when it comes to pheochromocytomas, these are called as a radiological chameleons. They have all pervasive radiological characteristics. They can have good washout as well as poor washout, and they can even have a baseline HU less than 10. The case reports of such POs do exist. Now, we at KM Hospital, Mumbai, we have got a law, we frequently get referrals for pheochromocytoma, so much so that over the years, we have accumulated a database of several hundreds of patients with pheochromocytoma. That gives us an opportunity as well as responsibility to see how we can characterize radiologically this interesting group of adrenal masses, the pheochromocytoma. So as we have just now discussed that the washout parameters as well as unenhanced early venous and delayed venous phase HU parameters have been studied for pheochromocytoma, and they do not help us differentiate with other lesions. But what has been lesser studied and lesser appreciated and talked about are the arterial phase parameters, the HU parameters in the arterial phase, and the wash-in parameters. Rather than talking about how much a lesion has washed out contrast, how much has it washed in or taken up the contrast from baseline level is what wash-in parameters mean. So at KM, we decided to undertake this study, and this was entirely the brainchild of our beloved colleague, Dr. Manjunath Goroshi. He tried to establish the radiological features of pheochromocytoma, which can differentiate it from other malignant adrenal masses, not adenomas, and the specifically paying attention to the wash-in characteristics. So we had 72 adrenal masses, 33 of them pheos, 22 of them adrenocortical carcinomas, and 13 adrenal metastases. We had few adrenal lymphomas as well. So what we found out in the study was how the pheochromocytoma as a group behave in terms of taking up the contrast and giving away the contrast when it is compared with other adrenal masses like adrenocortical carcinoma, lymphomas, and metastasis. So as is clearly seen in this figure, at baseline HU does not help us differentiate between these groups of masses. But pheochromocytomas being very vascular masses, they are very enthusiastic in taking up the contrast. They take up the contrast a lot of contrast and a lot early, so much so that the peak enhancement is achieved at arterial phase when the other masses are still taking up the contrast, and achieve the peak enhancement in venous phase when the pheo has already started washing out the contrast. So based on these characteristics, we try to look at the wash-in parameters which have got very good specificity for diagnosing it to be a pheochromocytoma. What we had seen that peak enhancement in arterial phase is a feature of pheo, while the other masses have peak enhancement in venous phase. In other words, the enhancement in our HU value in arterial phase for pheo will always be greater than venous value. For others, venous will be higher than arterial phase HU values. Then another thing which we had seen that all the pheos have absolute HU value more than 100, while all other masses had it less than 80 and 60 in arterial phase. Like we calculated the percentage washout parameters, we calculated a percentage wash in arterial enhancement parameter, and we have found that with the cutoff of 100%, the specificity for diagnosing pheo was 100% in our group of patients. We were happy that we were able to publish our experience in a reputed journal. To summarize that by doing this study, we were able to add one extension to the parameters, radiological parameters of adrenal masses, to say that pheos are rendered recognizable by certain wash-in parameters like arterial phase HU more than 100, the percentage arterial enhancement more than 100%, and the arterial phase HU being more than venous phase HU is what indicates a pheochromocytoma. With that understanding of the CT of adrenal masses, I would now like to share a few interesting experiences that we had at KEM about the adrenal masses. I would have loved if this had been a physical interactive dialogue rather than a monologue, which online setup offers. Now, this patient, 50 years old, was on follow-up at TMH, Tata Hospital, for management of CA lung. And during any point of his workup, he was done an FDG PET CT scan, which revealed a right adrenal uptake. If you can appreciate, this right adrenal mass is slightly enlarged, and the morphology of the lesion is like infiltrative adreniform shape. The other adrenal was okay. And if we look at the washout parameters, it was plain HU was 40, it was a lipid poor mass, and the washout was poor. And in the setting of primary extraadrenal malignancy, such morphology and such washout, it's easy to say that it might be a metastasis. A biopsy was done and it was proven to be a metastasis. Another patient, now this patient, though not precisely in oncology setup, but she had presented with abdominal pain, which revealed this mass. Now, if we look at this mass again, it is a poor washout mass, but almost simultaneously, she was also found to have a lung carcinoma, and this was also a case of metastasis, signifying that metastasis need not always be a small bilateral adreniform shape. It can grow to a larger extent depending on how late we diagnose them. Another patient, an operated case of CA carcinoma, was on follow-up with Tata Hospital, referred to us for this small adrenal lesion. If you look at it, the plain HU is 15, which is close to benignity, though not exactly benign, it's lipid poor only. But the washout patterns were good, giving us a confidence that this might be an adrenal adenoma, and we decided the patient to follow up and do radiology after certain interval to document an interval growth. Another patient, a CA penis patient, this time referred to us for a similar looking adenoma as that of the previous patient. But here, if we look at the arterial phase HU was 94, though not 100, but close to 100. The arterial HU was higher than the venous HU, which made us think that it might be a pheo. We calculated percentage arterial enhancement, it was more than 100%. So we thought it as a pheochromocytoma. We ordered a norepinephrine level which came high, confirming our diagnosis to be pheo, operated, and it was indeed a pheochromocytoma. Another patient, a lymphoma. Now, lymphoma, before chemo, he had underwent a FDG PET CT, which had shown FDG positive multiple lymph nodes throughout. Additionally, the adrenal mass was also there, which was very FDG avid. Considering this, this mass was initially considered to be a part of his general lymphoma burden. But he received chemo, and post-chemo FDG PET showed very good response to chemo in terms of resolution of other masses, but this adrenal mass remained. And then he was referred to us for evaluation. We did a proper adrenal protocol CT, in which we saw clearly that arterial phase HU is way high, 205. Arterial HU is more than venous HU. The percentage arterial enhancement was way higher. For us, it was a pheochromocytoma proven by doing a metanephrine level, and he was operated, and HPR indeed came out to be pheo. On similar lines, another patient, incidental detection of such mass. Now, this is again, arterial phase is higher. We feel that it is PO, arterial more than venous, but we did metanephrine levels and they came out to be normal. But so much so was our confidence in our findings that we went ahead and did even an MIBG scan to see whether it was PO, but it was negative. So we did an FDG PET CT, which revealed the FDG uptake in multiple bones like scapula and bone, as well as soft tissue around the hip joint. The biopsy from this lesion as well as from the adrenal mass proved it to be a sarcoma. Now, this was an important learning point for us, because we have encountered this patient after publishing our radiological workup for pheo, and the radiological, the pheo is bright because it is very vascular, and the differentials for a hypervascular adrenal lesion are very few. Pheo tops the list, and others being metastasis from a renal cell carcinoma, hepatocellular carcinoma, or a sarcoma. And this patient was indeed a sarcoma patient, which led to a hypervascular adrenal metastasis. Coming to the non-oncology setup, very common scenario, the CT being done for some unrelated reason. For this patient, it was constipation. And this was the morphology of the lesion. Very well circumscribed, although there is one speck of hyperintensity, but overall the plain HU was less than -5. Now, was less than 10. It was actually less than 0, -5. This gives us pretty much confidence that this is an adenoma and we need to follow this patient. Another patient did the CT for abdominal pain. If we can see, this was the lesion. Again, the washout parameters were poor. It was a lipid poor mass. But if we look at the arterial phase, the HU was 128 higher. Arterial HU higher than venous HU. We thought it was pheo, and indeed the metanephrine levels were very high. HPR was pheochromocytoma in this patient. Now, this mass, the way it looks at us, by just looking at the lesion, the heterogeneous mass with areas of necrosis, such a huge tumor, it was ACC without the need even for these poor washouts. His DHEAS levels were high. Post-operatively, they came down. HPR indeed came as adrenocortical carcinoma. This patient, young patient, abdominal pain, USG followed by CT done. Now this lesion, if we can see, it looks cystic, but what confirms it to be cystic is look at the HU values. The HU values do not increase at all. Even till the delayed phase of 15 minutes, the HU values are remaining almost the same. In radiological literature, if the difference between the HU values are less than 5, it is taken to be as the same HU values. So the same HU values till the delayed phase gives us confirmation that it is a cyst in this case. And in this case, because of the size, the patient underwent excision. It was indeed proven to be an endothelial cyst. Similar cystic lesion as was the case in previous patient. Now, if we would have kept the ROI in the center of the lesion, it would have uniformly came somewhere around 5 to 10. And it would have been same, and we would have labeled it as cyst. But as in contrast to the previous patient, the rim of the lesion is quite thick and it is enhancing. When we put carefully the ROI for taking the HU value on the rim, it came out to be arterial phase as 125. Again, arterial more than venous, higher PAE. We thought it to be pheo, and we ordered a metanephrine test, which came out to be normal. Confirmed twice, it was still normal. We went ahead and did an MIBG scan because we had very much faith into our parameters of pheo, which we had studied. It came out to be positive. He underwent surgery, and it was indeed an pheochromocytoma. The reason we believe for the normal normetanephrine levels might be an extensive necrosis and lesser number of cells left for producing the metanephrine's. Another lesion, subcostal pain, and then this is the mass that we see. Now, the characteristic feature of this mass, the size of the lesion and would make us think whether it is an ACC, but there is one thing which is very peculiar in this mass is the contrast is progressively increasing from plain to arterial to delayed venous. Even at 15 minutes, the mass is continuing to take up the contrast, and such progressive contrast enhancement is typical of a neurogenic tumor. So we operated this patient and indeed turned out to be schwannoma. So this, in our study, we found that progressively increasing the HU mass is what gives us a preoperative confidence of it to be a schwannoma. Now, another patient, 48 years old, who presented with severe flank pain and clinical symptoms of adrenal insufficiency, which was proven biochemically. It was a bilateral adrenal mass, a poor washout bilateral adrenal mass. When the lesion becomes bilateral, our way of looking at it changes because the etiology changes. For a unilateral mass, the most common etiology is adenoma, but when it comes to bilateral, the etiological spectrum changes. These two masses were very FDG avid, and on biopsy it turned out to be B cell lymphoma. Another patient, systemic symptoms, bilateral masses, enhancing heterogeneously on FDG PET CT, and here this turned out to be histoplasmosis. We had published our experience about the bilateral adrenal passes in 70 patients. Bilateral pheochromocytomas were the most common etiology in our group of patients, followed by tuberculosis, lymphoma, metastasis, and only 3 patients with bilateral adenomas. So this is another patient. Now we have to be clear. Sometimes we get across such tumors which we call as pseudoadrenal tumors. That means they are not adrenal tumors, but because of the characteristic location in that adrenal fossa, they might look like an adrenal mass, as was the case in this patient, which ultimately was proven to be hepatocellular carcinoma. With that, I would like to conclude that indeed CT plays a very important role in helping us understand what kind of lesion it can be, and in association with the clinical evaluation, the hormonal test, the functional imaging, it helps to plug everything together and reach at the final histopathology. Thank you.